Hey guys, welcome. I'm so glad to be with y'all today. So this is a Fertility 101, and I am really excited to be here to answer any questions that you have, and more importantly, give you some more information so that we can make hopefully your first visit with us a little less scary and kind of demystify some of the things that we're going to do. And sometimes it's really important to kind of plug that bug in your ear so that you can hear something not just for the first time. So let's get ready to rock and roll. All right, so getting started. So sometimes that first appointment is really scary, and I just want you to kind of know what's the basic workup that we're going to be recommending, and kind of talk a little bit about why we're recommending that particular workup. And obviously, everything is customized based off of, what you're coming in with and what previous workup you've already had. But let's just talk about all of them so that we can make sure that we're being comprehensive. So when we think about fertility, there's really four main things that we want to think about and evaluate, especially for the basic infertility workup. The first thing is we need to make sure we have eggs. So on our female partner side, we want to make sure that we have eggs, we're ovulating the eggs and releasing them, and more importantly, idea about what our ovarian reserve's doing. Then we need to look at the fallopian tubes, make sure the fallopian tubes are open, so that way that egg and sperm can meet. If they can't meet because the fallopian tubes are blocked, then, obviously pregnancy might be a little bit challenging, specifically the traditional way. Also, we want to take a look at the uterus to make sure we don't have any uterine malformations and that we don't have any issues like polyps or fibroids that can potentially impact fertility. Finally, for our male counterparts, we need sperm, right? So we need to make sure that we have good little swimmers that can make the incredible journey and hopefully result in a fertilization and a pregnancy. So how do we do this? So in terms of the blood work that we do, one of the most important things that we look at is your AntiMullerian Image. And this is essentially a marker for your ovarian reserve. Remember, we as women were born with the set number of eggs we'll ever have in our lifetime. And your AMH will give you an idea of not your ability to get pregnant, but rather your ability of how you're going to respond to ovarian stimulation, particularly if you were to do IVF or a less aggressive stimulation like Clomid or letrozole. So it can give us a lot of important information. Next, we want to take a look inside of the uterus and the fallopian tube. So we have two main ways to assess this. The first one is called a hysteroscopy and tubal catheterization. Now, this is something really interesting because we'll be able, while a patient is comfortably asleep, we'll be able to take a small little camera measuring 5.5 millimeters and without doing any incisions on the abdomen or whatnot, we can take a look directly inside of the endometrial cavity, directly inside where the pregnancy will hopefully implant and your baby will grow. And so the cool part about this is not only are we able to see, but we can take pictures so we can show you exactly what it is we saw. So this procedure is both diagnostic and therapeutic. What do I mean by that? Well, if we see any malformations, like we see a septum or we see a polyp or something like that, then we're able to take care of it at the time of the procedure. So that way, it's kind of like a one-stop shop. And we have the capability of looking at the little opening for the fallopian tube called the tubal ostia, and we can put a small little catheter, which is basically kind of like a straw, if you will, and we can put it right up against there and flush contrast through, and then we take an x-ray and we can tell this if your fallopian tube is opened or closed. So we can get all that information from that one procedure where you're nice and comfortable. Alternative to this is the HSG, or the hysterosalpingogram. That's a mouthful. So essentially, that is a very similar type of procedure, but there's a few key differences with this procedure. First of all, instead of us being able to look inside directly, we put a catheter into the endometrial cavity and you're awake during this procedure, so you might have a little bit of discomfort. But when we push the contrast through, then we can not only see the nice shape of your uterus to see if you have any possible uterine malformations, but we can also make sure that the fallopian tubes are nice and open. Now, this test is not quite as sensitive as the hysteroscopy in terms of evaluating for any lesions inside of the cavity, like polyps or something, but it can give us a good idea of uterus overall, and it's 50-50 if we're going to be able to catch subtle findings inside the endometrial cavity. Furthermore, sometimes, the uterus is a muscle. So anytime the uterus gets stimulated, it only knows how to do one thing and one thing only, which is to contract. And so sometimes you can have little tubal spasms, which basically means that the little areas or the little thin parts of your fallopian tube can go into spasm. And basically it can make your tube appear like it's blocked when in reality it could just be in spasm. So a lot of times, if that were the case, you might have to repeat this procedure on a different day, or you might want to consider doing the hysteroscopy and tubal cath to kind of help disprove if that's one of the issues that you have. Finally, for our male counterparts, we recommend a semen analysis. So it's really important because we know that a fourth of infertility can be male factor, and it can also be a mixture between male factor and a female factor, to look at the sperm and make sure that, our total amount of sperm is good. More importantly, our total motile sperm is looking good. And also look at something called morphology, which basically means looking at the general shape of the sperm. So this can give us a lot of information that we can use to kind of help tailor your treatment to something that will be most effective for you. So when we think about treatment options, what are the different options that we have at Houston Fertility Institute? Well, we have intrauterine inseminations, which are basically where we take a little catheter in clinic, and either me or one of my partners, so all physicians, will do the insemination. So basically you do a speculum, and then we have these little thin flexible catheters that we can use those natural curves of the cervix and basically bypass the vagina, the cervical mucus, the cervix, and the lower uterine segment, where we can get more of the active swimming sperm closer to the eggs. So that is one method of getting pregnant, is the insemination. And we have a few different ways of kind of stimulating your ovaries. We can use pills alone, like letrozole or Clomid, a combination of pills and gonadotropins, which are injectable medications. And then finally, using straight injectable medications called gonadotropins are all ways that we can stimulate the ovary or the female partner in order to prepare for an insemination. This is also a great fertility option and starting point for our same-sex couples. If we have two female partners, we can utilize donor sperm, or for our single partner to conceive on their own. Then we have what everyone kind of associates with fertility doctors, which is IVF, or in vitro fertilization. So this is kind of one of our most aggressive forms of treatment. And essentially what it is we'll use injectable medications or gonadotropins to help stimulate the ovaries to develop multiple follicles. And then when you're comfortably asleep, so usually that first part kind of takes about like 10 days on average. And then we do some ultrasound and blood work monitoring. And then when you look ready for retrieval, then your doctor will trigger you with a trigger shot. And then about 35 hours after your trigger shot, you'll come in for your egg retrieval. And the procedure is done where you're comfortably asleep, and we do everything under ultrasound guidance. So we're watching ourselves the entire time. Just like in the military, how they leave no man behind, well, we leave no egg behind. And so we go after every single little egg that we can find, and we get those. And then our colleagues, embryologists, will basically take each egg and fertilize it with one sperm. And then they're kind of like your early babysitters, and they kind of grow out the embryos until they're about day 5 or day 6. And then they can either freeze the embryo at that time, or they can do some genetic testing, which we'll talk about in a second. And then in a subsequent cycle, they can do an embryo transfer, where they'll basically allow your uterus and your pelvis to kind of recover from IVF. And then they'll start you off with about 12 to 20 days of estrogen exposure, followed by about 5 days of progesterone exposure. And then on that 6th day, they'll do the embryo transfer. Which is kind of like a similar type of procedure as the insemination, except we do it under ultrasound to be with us and all that stuff. It's a lot of fun. So this is really cool because this kind of gives you an idea of how everything looks in this certain kind of time points that we have for an egg to embryo progression. So on the far left of the screen, we have our egg. So that looks like a mature M2 egg. And then that's our goal, right? And so then we fertilize it, and then you get a 2PN. So that's what you find out your fertilization report when you get that on day 1. And then the embryo starts splitting and multiplying its cells. And then the very last image on the bottom right, you have a day 5 or day 6 embryo. And so that's what a beautiful blastocyst looks like, where here you have your inner cell mass, which will ultimately become the baby. And then around here, you have the trophectoderm, which will eventually become the placenta. So we said that we're going to talk about this. So PGT is pre-implantation genetic testing. And so the benefits of doing this is really recommended for women over the age of 35. But sometimes it's nice to know kind of if you're doing some family balancing or just kind of wanting to know what quality of embryos you have, it might be a good idea to do this. So that's kind of like one of the looser indications. But some of the benefits of PGT is that it increases your success rates per transfer. And that's predominantly because of the fact that a lot of times the most common cause of miscarriage in the first trimester tends to be genetic abnormalities. So if you transfer genetically normal embryo, then you theoretically have a higher likelihood of implantation and progression of your pregnancy. So your IVF rates do get higher when you have a PGT normal embryo. It also lowers your miscarriage rate, as we talked about. It minimizes your multiple pregnancy rates because you're more likely to transfer a single embryo because you know it's genetically normal. And then also you have the added benefit of knowing the gender. And so that might impact how you or what embryo you choose to transfer. Let's say you have 3 little boys at home and you are just dying for that little girl, then there you go. We have a way of kind of helping you out to complete your family.